Okay, thank you for all of the participants. Today I will present the result of our research about the association of specific cognitive domains and frailty status among older Taiwanese adults. My name is Lalu Suprawesta. I'm a PhD student at Graduate Institute of Injury Prevention and Control, College of Public Health, Taipei Medical University. For the introduction, as we know, frailty is a complex condition that affects individuals as they age and can lead to adverse outcomes such as falls, disability, hospitalization, and mortality. As the individuals getting older, they will experience the declining in physiological reserve, which result to vulnerability from the stressors. And this condition might increase the risk of falls, disability, hospitalization, and mortality as the adverse outcomes of their condition. As we see the figure also, its expected trajectory of decline in older adults with frailty at the end of life, when their functional status will decline with the increasing of age to the end of the life. For the data from Taiwan, the shared population of older adults age more than 65 years in Taiwan was projected have increasing from 60.1% in 2020 to increasing to be 20% in 2026. And also the prevalence of physical frailty so increasing among older adults from 8.4% in 2014 to be 17.6% in 2019. And following the study of frailty and cognitive frailty, in recent years, the study of cognitive impairment and frailty has gained increasing attention among the public health researchers as a potential link between these two conditions. Previous studies have shown that cognitive impairment such as dementia and mild cognitive impairment are often present among frailty older adults. And systematic review and meta-analysis of cross-sectional studies found a meaningful relationship between cognitive function and frailty among older adults, which where this condition present together might constitute an increasing risk of negative health outcomes in older adults. According to the cognitive function, individuals with poor cognitive function might be at risk for frailty. However, the evidence is sparse. And some previous studies found that the lower global cognitive increase the risk for incidence and progression of frailty. However, it is still unclear whether the difference come from the different cognitive ability or the answer or the specific cognitive will predict the onset of frailty, or the decline in domain of cognitive ability are more important risks than the others. And the result from longitudinal study found that poor executive function and greater decline in executive function were more strongly linked to frailty than the level or decline in psychomotor speed or memory. And finally, it's some study found the association about the decline in cognitive domains of executive function, processing speed, attention, and memory that associated with frailty. So despite this finding, further research is still need to explore the specific association between cognitive domains and frailty status among older adults. And the objective of our study is to explore the association between specific cognitive domains and frailty status among older Taiwanese adults. For the method, our study designs is observational cross-sectional studies. And our participants were the older adults who live in community dwelling and age 65 years old and more, who could ambulate independently, that recruited from Taipei Medical University Hospital, who visited outpatient clinic from August 2017 to December 2018. Most of the participants come from the community dweller living around the Metropolitan District of Senior District, Taipei City, Taiwan. The exclusion criteria for our participants were who who couldn't independently perform the basic activities daily livings, had some problem with the communication, have minor health problems such as advanced cancer, major cardiopulmonary disease, and dementia. We use some method to collecting the data in our study, like personal interview and performance test. We measure the data of frailty and cognitive function among older adults following the socio-demographic and lifestyle characteristic. And then we collecting also the data about pre-existing comorbidities and the medication. Also to test the functional measures of balance, activity, daily living, and depressive symptoms. For the measurement of frailty, we use the physical frailty measure from Frailty 2001 that they measure about 5 components, including unintentional weight loss, weakness, exertion, slowness, and low physical activity. Each components will have one score if they show the indicator among these conditions. And the way we make the frailty status by indicating the total score of 0 to 5, when 0 as non-frailty, 1 to 2 as pre-frailty, and more than 3 was considered frailty. For the cognitive function measurement, we use some measurement to assess cognitive function, including mini mental status examination or MMSE, Mattis Dementia Rating Scale or MDRS, digit symbol substitution test or the SST. For the MMSE, we use this assessment to assess the global cognitive function, while the MDRS and the SST was used to measure the 6 specific cognitive domains of attention, initiation, perseveration, contraction, conceptualization, memory, and processing speed. Another covariates also measured in our study, including the socio-demographic and lifestyle characteristic. Well, this data consists of age, sex, body mass index, educational level, monthly household incomes, regular exercise habit, current smoking, and regular alcohol drinking among their participants. We also collecting data about the pre-existing comorbidities, especially the chronic condition that examined using the list of 12 diseases, including hypertension, diabetes, heart disease, malignant tumors, respiratory tract disease, arthritis or rheumatism, gastric ulcer, liver disease, cataracts, kidney disease, gout, and spinal spurs. And also we collecting the data about the medication of this kind of disease. For the performance test of balance, we use T90 balance assessment that contains of 13 static and dynamic maneuvers that score the score range from 0 to 24. And also we use the activity specific balance confidence scale to measure balance. For the activity daily living, we use older adult research and services activity daily living scale that including basic activity daily living scale and instrumental activity daily living scale. For the depressive symptom, we use 15-item geriatric depression scale to measure the older adults who have experienced depression. For the statistical analysis, we use the distribution of participant characteristic across frailty status. And then we compare the characteristic participant across the frailty status using the t-test for ANOVA for continuous variable and person chi-square test for categorical variables. After that, we did the bivariable and multivariable proportional odds model analysis using ordinal logistic regression to investigate the association of explanatory variables and specific cognitive domains to having odds to have higher frailty status. Our results among our participants, where we have 730 participants eligible during study collection. There are 249 participants were men and 481 were women. and the average of their age was 71 years old. And the distribution of frailty status, most of our participants, above 50% of our participants were pre-frail, and around 11% were frail, and then the remaining participants were robust or non-frail. According to the specific cognitive domains among these participants, there are difference for the specific cognitive domains among our participants according to the frailty status, where we can see that the cognitive domains of initiation, perseveration, construction, conceptualization, memory, processing speed, and the global cognition that measured using MMSE showed the difference among the participants according to the frailty status. According to this data, we can see that participants who have pre-frail and frail showed the lower score of cognitive function, except the attention, which is not significant, while the other cognitive domains showed significant difference for the participants who have pre-frail and frail compared to participants who have non-frail or still robust. And the result for the multivariable proportional analysis of explanatory variable with the odd ratios and 95% confidence interval for the odds of participants who had a higher frailty status. After we did the stepwise method from the bivariable analysis, the final model of multivariable proportional odds model showed that age, woman, body mass index, regular exercise, number of comorbidities, genetic balance, the depressive symptoms, and specific domains of processing speed that measure using the SST have a significant to have a higher or lower to have association with a higher frailty status. Each one increase of age is associated with more likely to have a higher odds to have a higher frailty status in this participant, and being woman also have more likelihood to have higher frailty status. For the body mass index, participants who have overweight and obesity were more likely to have higher odds to having higher frailty status, while participants who did regular exercise have lower odds to have higher frailty status. And then the number of comorbidities, participants who have a higher number of comorbidities showed more likely to have odds to be higher frailty status. And then participants who have a 1 point increase of genetic balance have lower odds to having higher frailty status. For the depression scale, participants who showed the depression have a higher likelihood to have odds in higher frailty status, and participants who have higher point in the SSD score showed lower likelihood to have higher frailty status. So the finding in this study identified that the specific cognitive domain associated with the frailty status among older Taiwanese adults and the participant with pre-frail and frail had significantly lower scores in global cognition, MDRS conceptualization, contraction, initiation, perseveration, and memory, and also the DSST score that measures processing speed. After adjustment with the explanatory variable of age, sex, body mass index, regular exercise habit, functional balance measure, depression, number of comorbidities, and global cognitive function, a 1 point increase in the SST score that measures specific domain of processing speed showed significantly independently association with lower or to have higher frailty status. The findings was constantly related from the previous study, like the higher level of physical functioning was significantly associated with the lower, with the higher processing speed and executive function in community during older adults, and the greater decline in processing speed associated with the greater decline in walking speed. Some of the component in frailty status showed the associated with the processing speed according to previous study. And also the slower processing speed as ability to predictive of frailty, predicting frailty in subset particular of robust participant to predict the increasing risk of frailty in older adults. And then the reason of the declining in processing speed, reasoning, memory, and executive function, some of which is underpinned by age-associated cognitive decline, according to the finding from the previous study. And the frailty prevalence is higher among women and increase with age in both genders. The development of frailty in women might influenced by deficit of various hormones during aging and could increase the inflammatory states. And then the importance of regular exercise and the ability to maintaining good physical function in older adults is could preventing the or delaying the frailty among older adults. So according to our study, the study used a range of potential explanatory variable to being a control, and some limitation also could notice from our study that our study is a cross-sectional study design, so we couldn't find a causal mechanism among cognitive function and frailty. And then the use of Matisse dementia rating scale to assess specific cognitive domains may not sensitive to be measurement of cognitive function in our study. And also the sample size was relatively small and limited to a specific geographic area. So the generalizing of our finding is should be by a caution. The conclusion: assessment on specific cognitive function of processing speed might predict the older adults who had at risk of frailty, and the findings suggest that healthcare professionals should prioritize to identify the frailty status and cognitive impairment among older adults during their routine screening and assessments. And the underlying mechanism of this cognitive function for the role in development of frailty need to investigate in future studies. Maybe the prospective studies might help to the insight of causal and direction of cognitive function decline in and progression of frailty. Thank you for the attention. That's all my presentation. We open question and criticism.